So overview of today's presentation will be in brief introduction to the anatomy of skin, common skin lesion, infectious skin lesions, neonatal dermatosis that can be inherited skin conditions, neonatal skin emergencies that can present in the newborn period, normal skin findings if time permits, and take home messages. So, introduction, the skin acts as a primary barrier against infection, thermoregulation, and electrolyte homeostasis. Neonatal skin is thin and fragile when compared to adult skin. It is immature. Neonates are more vulnerable to transepidermal water losses, injury from heat, irritants, and mechanical trauma. The newborns have limited skin flora and they have limited natural skin microbiome. So they have this predispose them to higher risk of colonization of pathogens. They also have increased body surface area to body mass ratio. So there is increased percutaneous absorption of substances like chlorhexidine application, alcohol application, betadine application can lead to neurological issues or iodine toxicity, respectively. Like as the skin matures, the barrier function improves, and the babies will have increased skin thickness, skin tension, and better developed pigmentary and agnate cell structures. So disruption of the skin can be due to any genetic mutation, injury. It can be a chemical injury, physical injury, or biological injury, infection, or it can be due to prematurity. So this is the developmental milestone of skin in a glance. During the gastrulation period, the embryo is covered with a single layer of keratinocytes that is called as epidermis. As the gestation progresses, there is expression of the surface keratin by 6 weeks. There is specialized epithelial cells that are migratory cells, melanocytes from the neural crest cells and Langhart cells from the reticuloendothelium system that localizes to the skin by around 8 weeks. After the epidermis is formed, like keratinocytes are formed, the surface keratin is expressed and specialized cells are formed. The dermis formation starts by around 8 weeks. So the junction between the epidermis and the dermis, namely the hemidesmosomes, anchoring filaments, anchoring fibrils, and type 4 collagen that develop by around 8 to 10 weeks. Beginning of nail development is by 10 weeks and it is complete by almost 5 months. So when we see a extreme premature baby born at 23 or 24 weeks, tails almost covering the nail bed. So eccrine sweat glands develops around 10 to 12 weeks. Beginning of hair development in the hair canal develops by 12 weeks and it is complete by around 20 weeks. Blood vessels, vasculogenesis are developed till 20 weeks and after 20 weeks there is angiogenesis. Sebaceous glands develop around 13 to 16 weeks. Formation of collagen is from 15 weeks. So before 15 to 20 weeks, when the baby is injured, when the fetus or embryo is injured during chorionos villus sampling or amniocentesis, there will not be any scar formation because there is more of collagen and less of elastic fibers. This elastic fibers is responsible for the scar formation in the skin. So less than this 20 weeks, there will not be any scar formed in a baby. Apocrine sweat glands in the rest of the baby body other than palms and soles are formed by around 24 to 26 weeks. So this is the anatomy of the skin. We can see that the skin is composed of epidermis, dermis, and the adipose tissue. In the epidermis, there are 5 layers. The basal layer, spinous layer, granular cell layer, and stratum corneum. In between stratum corneum and granular cell layer, there is a layer called the stratum lucidum that is not well developed in neonates and it is present mostly in the palms and soles even in adults. So these are the 4 layers in the epidermis. This will be important when we are dealing with miliaria or Staphylococcus saldes skin syndrome or epidermolysis bullosa. And this is the epidermis, dermis, and the adipose tissue. This is the basement membrane layer where the epidermis and dermis are joined together through hemidesmosomes, and the layers of basal cell layer are lamina lucida and lamina densa. This is important when we are dealing with epidermolysis bullosa. So these are the morphological skin diagnosis that we write as a symptom. So macule is a flat area of color change. There is no elevation or no depression. There is no scales. This is less than 0.5 centimeter. So more than this, it is called a patch. Papule is a solid elevation that is less than 0.5 centimeter. If it is more than 0.5 centimeter, we call it as nodule. And if it is more than 1 centimeter, we call it as a tumor. So plague is a mixture of macule and papule. I mean, it is elevated, but it has a flat surface. Scales are flakes of conified skin layer, and crust is a dried exudate on the skin. Example like impetigo, where we have a honeycomb like honey colored scales. Fissure is a crack in the skin. Ulcer is an area of destruction, partial or complete loss of skin epidermis. Scar is excess collagen production after injury. Wheal is a type of plague. It is a result of transient edema in dermis, and we mostly encounter this in a urticaria patient where it is very transient and resolves in 24 hours. Vesicle is a small blister. Usually it is told to be less than 0.5 centimeter, and bulla is more than 0.5 centimeter. When this bulla and vesicle is filled with pus, it is called a pustule. And atrophy is a loss of some portion of the skin. With this base, we follow the skin conditions. So the basic difference between preterm and term skin are the skin thickness is less in a preterm baby, 0.9 mm compared to 1.2 mm in a term baby. Epidermal thickness is also low. Epidermal covering has no vernix before 28 weeks. So we all know that vernix is produced by from 28 weeks. Because of this thin skin, there is high rate of transepidermal water loss, which can be more than 45 gram per meter square per hour, whereas it is low in a term baby. Percutaneous absorption of skin is also very high in a preterm baby, whereas it is not so much in a term baby. Coming to common benign rashes, we have encountered erythema toxicum neonatorum in a majority of newborns in postnatal rounds. It usually appears on the second or third day after birth, but it can also develop within 24 hours, or it can develop as late as 2 to 3 weeks, but it usually resolves in 5 to 7 days. The cause of this erythema toxicum neonatorum is it is a benign inflammatory condition. The inflammation can be due to any bacteria or fungus that is residing the hair canal. So it presents as a 2 to 3 mm erythematous plaques. So in this baby, we can see that there is multiple plaques. Papules. There is like small elevated red color lesion. This will change into localized yellow color pustules that will resolve on its own. So it begins as a 2 to 3 mm erythematous papule evolving to pustule with erythematous blaze. It gives a flea-bitten appearance, something like flea-bitten appearance it gives. It commonly involves the face, trunk, and proximal extremities. Palms and soles are typically sparred. In right stain, it reveals the presence of eosinophils in pustules. In severe erythema toxicum neonatorum, where there is systemic involvement, they can have 15 to 25% of babies can have transient systemic eosinophilia. Erythema toxicum neonatorum is more common in white babies, whereas transient neonatal pustular melanosis is more common in infants with dark skin. So it is also a benign self-limiting condition. It presents in the first few days after birth in 3 clinical phases. So first it will be a 2 to 10 mm superficial sterile pustules that are very fragile, and it will break on its own, and it ruptures to reveal a collarette of fine scales that will heal with the hyperpigmented macules, and this hyperpigmentation takes almost weeks to months to resolve. So the diagnosis, as opposed to eosinophils in erythema toxicum neonatorum, there is presence of neutrophils. However, no treatment is necessary, and self-resolution is the norm. So here we can see that the baby in the scalp and here the baby is having, there is no erythema over the base, but the baby is having multiple pustules. So here also we can see that in the neck area, there are multiple pustules without much of erythema. The second condition is due to neonatal and infantile acne. When it occurs very early in the neonatal period, it can be due to maternal androgens, or it can be due to endogenous androgens that is usually elevated in the mini puberty period, that is from 1 month to 6 months. The cause is same as in adult acne, it is due to overgrowth of Malassezia furfur and subsequent allergic reaction to this fungus. So it can present with open or closed comedones, papules, pustules, and rarely cyst. Malassezia colonization begins in a baby at birth and it increases in the first few weeks. So, in the first week, around 5% of the neonates are colonized with Malassezia furfur, whereas in week 2 to 4, around 30% of the neonates are colonized. The neonatal acne is early onset and it usually resolves by 3 months of age. And infantile acne usually occurs after 3 to 6 months of age, and it resolves, the individual lesions resolves in like 4 weeks or 5 weeks, but it can have a waxing and banding course that can last for years. Usually, this acne is self-resolving, no treatment is needed. However, like similar to adult acne, topical antibiotics, benzyl peroxidase, can be used. Isotretinoin, topical or oral, can also be used in severe cases. When there is severe intractable acne, we should rule out a congenital adrenal hypertrophy or hyperandrogenism, where this increased androgen is the cause of acne. So this is a internet picture showing like baby having comedones. Some books and papers say neonatal cephalic pustulosis is same as neonatal acne, but some references say they both are different, with neonatal cephalic melanosis different from acne by typically lacking comedones. Otherwise, these also have like papules, pustules, cyst, and they develop between 5 to 30 days, and it is also associated with Malassezia colonization with subsequent anti-inflammatory reaction to Malassezia. Diagnosis is by GMSA stain that yields yeast and neutrophils. This is also a self-limiting condition. Lesions can take months or years to resolve. It can be treated with ketoconazole containing shampoo or topical 2% ketoconazole and low potency steroids. This is a picture. Here we can see that baby is, in addition to having this pustules, baby is also having papules and lesions in various stages of development. So this will differentiate this from transient neonatal pustular melanosis, and this develops later than the previous condition. Seborrheic dermatitis, also known as cradle cap, it is commonly affecting the scalp, forehead, and nasolabial folds. It can also involve chest, abdomen, and intertrigus creases, typically in the diaper region and in axilla. Here, it can be confused with diaper dermatitis or intertrigo. It appears between the 2 to 10 weeks of age and appears as salmon-colored patches with greasy yellow scale, and it resolves by 1 year of age. This is also caused by overgrowth of Malassezia furfur and subsequent inflammatory reaction against this fungus. DDs are atopic dermatitis. However, as opposed to atopic dermatitis, when it develops by 3 to 6 months, seborrheic dermatitis have an earlier age of onset. And it involves more of scalp than of atopic dermatitis. It can also be confused with psoriasis, which is relatively rare in newborn period. Langerhans cells histiocytosis, where there is refractory seborrheic dermatitis. Superficial fungal infections. Mild lesions of seborrheic dermatitis are self-limited and resolve spontaneously with emollients, gentle combing, and frequent gentle washes. Like we can advise the parents to give a head wash every twice weekly or thrice weekly. If the lesions are not resolved, then ketoconazole or low potency topical steroids can help. It overlaps with the atopic dermatitis when the baby grows older, and it is difficult to distinguish. And studies have shown there is increased incidence of atopic dermatitis later in life in babies known to have seborrheic dermatitis. Olive oil application practiced in many parts of India should be avoided because it increases the yeast growth. So this is a picture showing neonatal seborrheic dermatitis, where there is like yellowish brown plaques in the scalp. This is a severe seborrheic dermatitis involving the face region. This can be confused with the atopic dermatitis, which also involves the face with severe scaling. So So malaria is a skin disruption caused by obstruction of the eccrine glands, that is sweat glands, caused due to thermal stress, and it can occur in the first few weeks after birth. There are three types: Miliaria crystallina, Miliaria rubra, and Miliaria profunda. Miliaria crystallina and rubra are relatively more common than profunda. Crystallina is asymptomatic, just present with superficial clear vesicles with no inflammation. However, rubra can be confused with other lesions. It occurs due to obstruction in the mid-epidermis. So it presents with a pinpoint erythematous papules or pustules. It can be due to overheating or fever. It presents in the head and neck, face, or in the trunk region. It is associated with skin erythema and pruritus. Symptomatic management like bathing twice daily, using cotton cloths, cooling measures, use of AC, avoiding excessive bundling can help. However, if it is refractory, low potency steroids can produce rapid symptomatic relief. It resolves within days. Recurrent miliaria rubra, type 1 pseudo hypoaldosteronism should be ruled out, which causes recurrent dehydration and increased temperature. So this is a picture of miliaria crystallina. So it appears as a clear vesicles without any erythema in the base. The babies will not have any itching, and this will rapidly disappear in 1 to 2 days without any management, just with cooling measures. This is Miliaria rubra. Here the baby is having pinpoint papules in the face, trunk and back region. This is due to overheating or fever. This may take like 1 week or 10 days to resolve. So diaper dermatitis. Diaper dermatitis is just a symptomatic term. The cause can be a friction dermatitis due to wipes use. These commercial wipes have various emollients and chemicals that can cause irritant contact dermatitis also. And the diaper material itself can be irritant, or it can be due to superficial bacterial or fungal infection. So it presents with a erythema and mild scaling in the flexural region like gluteal crease, buttocks, perianal region, and convex pubic surface. The areas which is not in contact with the diaper, like this gluteal fold, these regions will typically be spared. It can be due to multiple factors. Because of constant use of commercial diaper, there will be occlusion and decreased air circulation. And with friction of commercial wipes, maceration of the area due to stool passage or urine passage, and long diaper usage, it compromises skin integrity. Superimposed to that, there is a chemical irritant, chemicals present in the urine, feces, or commercial wipes, or biological irritants. Like any microorganism, bacteria or fungal, can also cause diaper dermatitis. Prevention is by maintaining of skin barrier by using barrier substances. It can be petroleum jelly or commercial zinc oxide cream, or it can be simple coconut oil application. The disposable diaper, it decreases the incidence as opposed to commercial reusable diapers. Low potency steroids can help, or topical antifungals can help in case of candidal infection. So this is a picture of, this is two pictures of diaper dermatitis. Usually the most common diaper dermatitis, it presents with just erythema, blanching or non-blanching erythema. In more severe cases, there can be papules, there can be macules, there can be pustules. There are like satellite lesions. This point towards candidal infection. So usually we have erythema. In more severe cases, we have papules, vesicles, pustules, ulcers, erosions, etc. So this is a simple case of like maybe erythema present in the diaper region. These are differential diagnoses of diaper dermatitis: frictional dermatitis, irritant contact dermatitis, candidal diaper dermatitis, or intertrigo, seborrheic dermatitis that present in the atypical location like groin, or inverse psoriasis, granuloma infantum, etc. These are differential diagnoses of diaper dermatitis in cases where it is severe and not responding to treatment. It can be due to zinc deficiency presenting as acrodermatitis enteropathica, or it can be due to LCH also. Umbilical granuloma is more commonly encountered. It is due to excessive granulation tissue. So once the umbilical cord falls off, there is a granulation tissue beneath and it disappears with epithelialization of the umbilicus. With epithelialization of umbilicus, there is no watery discharge, mucoid discharge or blood discharge. If it is insufficiently epithelialized, there is a excessive granulation tissue. So they can present with friable grayish pink mass that is 3 to 10 mm size, that is vascular with velvety appearance in the umbilical region. Associations are moist cord care. So we advise dry cord care. So moist cord care can increase the incidence of umbilical granuloma, long corded, delayed cord separation, infections, low grade bacterial infections, foreign bodies in the umbilicus can all lead to umbilical granuloma. It can be treated with silver nitrate application or isopropyl alcohol, topical steroids or ligation. Or more commonly used salt application can also be tried. The important differential diagnosis are umbilical polyp. And before diagnosing umbilical granuloma or umbilical polyp, in case of umbilical discharge, we should be careful to rule out patent urachus or patent vitellointestinal duct. So this is a umbilical granuloma presenting as a velvety vascular polyp, about 3 to 10 mm size in the umbilical region. Coming to infectious skin lesions can be bacterial, viral, fungal, or parasitic infections. Uh, the blueberry muffin baby is not directly due to infection, but it can be due to torch infections or leukemia cutis. Here, it is due to extramedullary hematopoiesis. So, the extramedullary hematopoiesis occurs in the skin. The baby will present as eruptions of violaceous infiltrative papules and nodules which are present at birth. These are signs of extramedullary hematopoiesis. The size may range from 1 to several mm in size. They do not blanch on touch. They occur in the head, neck, and trunk region. Usually, it fades by 3 to 6 weeks of age. Blueberry muffin baby, as such, does not require any treatment. But the cause of this blueberry muffin baby should be worked out. It can be due to congenital torch infections like toxoplasmosis, syphilis, varicella zoster, parvovirus, rubella, or CMV, or it can be due to leukemia cutis. Leukemia cutis is a cutaneous manifestation of underlying malignancy. It can be a myeloblastic leukemia, or it can be Langerhans cell histiocytosis, or any solid tumors also. Neuroblastoma is also an important differential diagnosis. Biopsy may be needed to confirm underlying diagnosis in a blueberry muffin baby. So this is a big picture showing a baby with blueberry muffin lesions. So there is varying size of this extramedullary hematopoiesis. This usually fades on its own, and the baby will not be overtly symptomatic or require any life support, but working up of the underlying disorders is more important. So hereafter, the viral infection, fungal infection will be divided into congenital infections, which is acquired in utero, and neonatal infections, which are acquired postnatally. So congenital varicella. Congenital varicella occurs in newborns born to women with primary infection of varicella zoster, which is actually chickenpox, before 20 weeks of gestation. So the infection has already occurred in utero and healed in utero. So when the baby is born, the baby can present with reactivation of a previously healed disease. So the baby will present with red macules, vesicles in the dermatomal distribution, or the vesicles that was present previously could have healed with scarring. So the baby will present with red macules, vesicles, or scarring in the dermatomal distribution. It can be associated with extracutaneous findings like limb hypoplasia, ophthalmic findings like microophthalmia, chorioretinitis, neurological findings like cortical atrophy, microcephaly, encephalitis, and organ defects. There can also be gastrointestinal, genitourinary, and cardiovascular abnormalities. So, in a mother with a primary chickenpox, prior to 20 weeks. Level 2 ultrasound scanning and perinatal counseling is very important to opt for continuing of pregnancy. Mortality in case of disseminated infection is almost 30%. Coming to neonatal varicella, neonatal varicella will present if the baby has acquired infection in the last few days of pregnancy, or in the first, if the mother has acquired infection in the last few days of pregnancy or in the first few days after birth. The clinical manifestation can be a mild self-limited skin disease with papules and vesicles, or it can be a severe disseminated infection with hepatitis, pneumonitis, meningoencephalitis, DIC-like picture, with high mortality of almost 30%. Premature infants with birth weight of less than 1000 grams, there is high risk of systemic disease in the first 6 weeks after birth. So hospitalization and isolation of these babies are very important. So they can present with disseminated erythematous papules, vesicles, or erosions with pneumonia, hepatitis, and meningoencephalitis and coagulopathy. Diagnosis mostly clinical with a history of chickenpox in the mother. The detection of viral DNA by PCR or direct fluorescent antibody reaction, or the serology, IgA and IgM, can point towards active disease. Neonatal varicella usually needs treatment, and it is treated with varicella zoster immunoglobulin. Immunoglobulin should be given along with IV acyclovir of 20 milligram per kg every 8 hourly for 5 to 7 days. So this is one of our babies who was born to mother with chicken pox. This baby was a very low birth weight baby, presenting with skin lesions in almost 12 days postnatal. This baby required IV acyclovir and was discharged in a good herpes simplex virus. It can be due to congenital or neonatal virus. So congenital can be acquired in utero, so it can be a ascending genital infection or transplacental spread. But this contributes to only 5% of congenital herpes simplex virus. 85% of herpes simplex congenital infections are through during delivery through infected birth canal, and 10% of herpes simplex virus are acquired postnatally, and it present as neonatal herpes simplex virus. The clinical presentation of congenital and neonatal are almost similar and overlaps. The clinical presentation can be mild to severe with neurological sequelae or death. There is increased risk if the primary infection occurs near term. So if the mother is already HSV1, and if the mother gets new HSV2 also, it is considered as primary infection, and there is increased risk of spread. So congenital lesions, they present with skin lesions at or within 12 hours after birth. And these lesions can be hemorrhagic also. And they, along with skin lesion, they have systemic manifestations. More commonly, CNS manifestation, they present with hemorrhagic encephalitis involving the temporal lobe. And there will be autonomic dysfunction, like baby can have hyperthermia, hypothermia, heart rate variability, respiratory rate variability, and color change. So this is one of congenital herpes simplex virus. They present with a hemorrhagic plagues or bulla at birth. These babies are treated with IV acyclovir, and this is like 10 days after IV agangliocyclovir, where the lesions are healing. So neonatal herpes simplex infection is due to postnatal acquisition. They can present with 3 distinct manifestations, which can be overlapping also. They can have skin, eye, mouth disease, that is short form called as SEM disease, in 45% of the infants, and CNS infection in 30% of the neonates, and disseminated infection in 25%. Disseminated disease presents as a sepsis only. Fever, hypothermia, lethargy, DIC, liver involvement, hepatitis, or conjugated hyperbilirubinemia, and respiratory involvement. The skin lesions will be 2 to 4 vesicles with surrounding erythema, that is more common. However, they can present just with CNS infection or disseminated disease with no skin lesions in around 20%. Diagnosis through herpes simplex virus DNA PCR. Serology has no role in the diagnosis. The neonate should be treated with isolation, evaluation, and IV antiviral therapy as compared to 7 days for varicella zoster. These babies are treated for 21 days. Or in case baby CNS disease is not resolved even with 21 days, till the DNA PCR is negative, we can be giving IV ganciclovir. But persistence of DNA PCR positivity even after 21 days is a poor prognosticate marker for further neurological outcome. So this is a MRI picture showing a temporal lobe hyperintensity suggestive of encephalitis. So impetigo is a relatively benign skin condition, localized skin infection caused by streptococcus or staphylococcus. It can be non-bullous or bullous types. So this is the non-bullous type. First picture is a non-bullous type. We have already seen that bullous is a fluid containing vesicle that is more than 0.5. Since it is very superficial and it can be eroded often, and it usually presents with scale. So the primary lesion is a bulla, and the primary lesion would have been bulla, which now has eroded to form ulcers. This is a bullous type of impetigo, and this is usually caused by staphylococcus. Here, the baby is having small pustule or vesicle, small less than 5 mm, and it is having a erythematous base, and it is localized. So this can be a non-bullous impetigo, and it can be caused either by streptococcus or staphylococcus. But bullous impetigo is usually caused by staphylococcus infection. So non-bullous eczema usually has honey-colored crust. They rupture as a result of rupture of thin superficial vesicles. The clinical presentation is diagnostic. However, they have risk of systemic spread of infection. Like baby can present with impetigo, but subsequently can develop MSSA sepsis or MRSA sepsis with pneumonia, osteomyelitis, or septic arthritis. Localized lesions are usually treated with mupirocin. However, if it is severe or widespread, oral or IV antibiotics may be needed. As compared to impetigo, which is caused by direct virus, Staphylococcal scalded skin syndrome is caused by toxin-mediated reaction. So, whereas the pus culture will reveal the organism in impetigo, Staphylococcal scalded skin syndrome will have no blood culture or skin swab culture positivity, because it is due to exfoliative toxin. It can be due to a trivial infective foci elsewhere in the body, like conjunctivitis, skin localized impetigo, ear, or umbilicus. And it is due to exfoliating toxin ETA or ETB, causing widespread blistering and desquamation. Cultures are usually sterile. They present with a generalized erythema with wrinkled appearance and sheet-like superficial desquamation. It usually develops over 2 to 5 days of onset, and they have a positive Nikolsky sign. Nikolsky sign is positive in any lesion where the tensile strength of the skin is lost, like staphylococcal scalded skin syndrome, toxic epidermal necrolysis, TEN syndrome, or epidermolysis bullosa. So in any skin condition where the tensile strength of the skin is lost, they present with a positive Nikolsky sign. As opposed to which is caused by staphylococcus, these babies are increased risk of gram-negative bacilli systemic sepsis, especially Pseudomonas aeruginosa. Diagnosis by Sang smear, they reveal large polygonal epithelial cells with no inflammatory cells. Treatment is just a supportive care management and antibiotics. Clindamycin should be added. Even though it is a bacteriostatic drug, it reduces the toxin production and should be added in all cases of staphylococcal scalded skin syndrome. Usually, it recovers in 10 to 14 days without scarring or long-term complications. This without scarring is an important differential diagnosis as compared to 10 or other diseases which involves the epidermodermal junction. However, the complications are excessive fluid losses, electrolyte imbalance, temperature dysregulation, infection or sepsis, and malnutrition due to loss of nutrients. So this is a picture baby presenting diffuse erythroderma, where the involvement of skin is more than 90%, with generalized erythema, scaling, and there is a loss of skin barrier. These babies are at increased risk of gram-negative bacillus sepsis. So scabies, we have seen viral infection, bacterial infection. So we'll be seeing parasitic infection and subsequently fungal infection. Scabies is caused by Sarcoptes scabi. It is a mite living in burrowed tunnels within the epidermis. This is it causes intense itching, and it is transmitted by direct human contact with infected person. Mites do not survive greater than 24 hours outside the human body. So the primary lesion is a burrow where the scabies lives. But secondary lesion can be a vesicle, pustule, papule, or ulcers or pustules. It can be vesicles, pustules, papules on the head, palms, soles, axilla, genitals, and scalp. Diagnosis is by scapping a burrow or flesh palpule and examination under oil. It will show identification of the mite, eggs, and feces. Treatment is permethrin 5% whole body, including the scalp, which is used off-label in a newborn baby, but it is widely used. The drug of choice in a neonate is 6% colloidal sulfur. Household contact should also be treated. Scabies nodules, which is due to hypersensitivity response to scabies antigen, can be present even after successful treatment of scabies. It will resolve in weeks to months. So we can see that in the leg of the baby is presenting with papules, few pustules, and baby has itched, and it can, baby has eroded the lesion, and it can lead to ulcer formation also. So this is a widespread like papule and pustule formation, and it can be present in atypical locations like head, face, and palms also. Congenital cutaneous candidiasis. So we are seeing fungal infection. As with others, congenital infection is caused by in utero causation, where in women with history of candidal vulvovaginitis. Risk factors are IUD when the mother has conceived, cervical suture in situ, invasive procedure or extensive instrumentation. Causes of preterm labor, it can cause preterm labor, chorioamnitis and funicitis, which is inflammation of the cord. It usually presents as a skin lesion with diffuse erythema with or without erythematous papules or pustules, occasional bulla predominating in the back, extensor and skin folds. However, it always involves the palms and soles. Nail abnormalities can also be present at birth, and it presents with as onychomycosis. Um, uh, in extreme preterm and ELBW babies, this congenital cutaneous candidiasis can progress to systemic infection. Systemic infection is present in 67% of ELBW babies as compared to 10% if the birth weight is more than 1000 grams. Antifungal treatment for congenital cutaneous candidiasis, it has no benefit. But in cases where it has progressed to systemic infection in ALBW or extreme preterm baby, then antifungal treatment is warranted. So this is a infant picture of onychomycosis. This baby is presenting with a diffuse scaling and skin erosion suggestive of congenital cutaneous candidiasis. It occurs in utero infection in women with history of candidal vulvovaginitis. Neonatal candidiasis, it presents after the first week. It is acquired when passing through the infected birth canal or as a result of procedures that can breach the skin infection. It can present as localized disease like oral thrush, intertrigo or diaper dermatitis or systemic infection. Or it can be a systemic symptoms like in premature or immunocompromised individuals presenting as respiratory symptoms, hyperglycemia, temperature instability, hypotension, UTI, meningitis, and septicemia. It is usually diagnosed with smear of pustules using KOH. Spores and pseudohyphae can be present. Evaluation is through blood, urine, respiratory, and CSF cultures. Treatment is through IV amphotericin B. Fluconazole in case of UTI can be considered. Pityriasis versicolor is also a fungal infection that present in relatively older neonates and in the infant age group. It is due to superficial fungal infection that is localized to the stratum corneum caused by Malassezia globosa and furfur. It presents as fine, scaly, hypo or hyperpigmented macules or papules with well-defined borders located in the upper trunk, neck, and arms. Face, uh, face is more commonly involved in children. Predisposing factors are in the summer seasons, usually where there is hot and humid environment, where there is excess of sweating, and family history of pityriasis versicolor can be present, where there is excessive sebum secretion, application of oily lotion or cream, which can promote the fungal growth, and genetic predisposition can also lead to pityriasis versicolor. Diagnosis is basically clinical only. KOH mount of the lesion will reveal stubby hyphae with cluster of spores, typically called as banana and meatball appearance, or spaghetti and meatball appearance. Treatment is through topical antifungal therapy. In case of extensive lesion, frequent recurrences or refractory to topical therapy, systemic antifungals can be considered. In case of frequent recurrences, long-term intermittent prophylaxis can also be considered. So hyperpigmented lesions can be due to direct damage to the melanocytes and inhibition of tyrosinase. Hyperpigmented lesions can be due to inflammatory reaction to the Malassezia furfur. This is a systemic antifungal therapy. Azole, terbinafine, butinafine, cyclopiroxolamine, or non-specific topical antifungals like selenium sulfate, zinc pyrethroid. Many of this we use for seborrheic dermatitis also. Or oral antifungals like itraconazole and fluconazole can also be used. So here we can see that the baby is having relatively well-defined. It is typically called as pencil-lined borders. Well-defined hypopigmented. This can also be hyperpigmented also. It usually presents in the face, neck, and upper back. And family history can also be positive. It usually occurs in the summer seasons where there is excessive sweating. So here also we can see that there is a well-defined pencil-lined borders. This should be differentiated from pityriasis alba. It is a minor manifestation of atopic dermatitis and is associated with history of atopy. Here, these lesions are relatively more common in infantile age group and toddler age group. They present with a ill-defined border of ill-defined perioral in the nasolabial fold, hypopigmented lesions without any typical well-defined border, just some hypopigmentation. They are ill-defined macules with thin plaques or patches. Circular oval with mild scaling and pruritus. It usually present in the face, cheeks, and arms and upper trunk. It is mostly a cosmetic problem. It usually has a self-resolving course. The individual lesions will resolve like 1 month or 6 weeks, but it can have a waxing and waning course. The resolution period can be from several months to 1 year. Reassurance, low potency topical corticosteroids can be tried like 1% hydrocortisone treatment for the shortest period possible and mild emollients. DDs are post-inflammatory hyperpigmentation in case of eczema, irritant or contact dermatitis, which has healed and with a residual hypopigmentation, and pityriasis versicolor, which has a pencil-lined borders. So autoimmune lupus is a relatively rare condition. It presents with erythematous plaques with central scaling and atrophy. Characteristic annular lesions. This is a article picture showing annular lesion with central clearing that is mostly present in the face and in the upper trunk. They have annular lesion in the periorbital area, cheek and forehead, spreading to the trunk and extremities. Treatment is by low to medium potency topical corticosteroids. They usually resolve spontaneously by 6 to 12 months. adequate skin protection is needed because they can have residual dyspigmentation because of skin atrophy. Systemic complications should be worked out because a mother is a known case of lupus, like a heart blocker, hepatobiliary diseases like transaminases, CNS involvement should be looked for. Coming to interesting group of neonatal skin condition, neonatal dermatosis. So first and relatively more common neonatal dermatosis is ichthyosis congenita that presents as colloidal baby lesion. This is like a colloidal baby is a symptomatic diagnosis in any baby where there is like a thick plastic membrane that is enclosing the baby. It can be very mild that we can encounter in a postnatal ward or in a well baby, or it can be severe with high risk of mortality. So this is a symptomatic diagnosis. Actually, it is a phenotypic diagnosis. However, the underlying differential diagnosis can be wide. It can be inherited ichthyosis, a type of neonatal dermatosis, or it can be Gaucher's disease, a metabolic disease, ectodermal dysplasia, or vitamin deficiency. Down syndrome can also cause a colloidal membrane, and it can present as thick parchment-like encasement of skin along with growth restriction, hearing and eye problems, infection, and thermoregulation. These are encountered in a severe case of colloidal membrane. The taut skin can lead to ectropion and eclabium, flattening and hypoplasia of the nose and ears, and it can lead to pseudocontractures. One cause of colloidal membrane is inherited ichthyosis. Inherited ichthyosis can be syndromic, where the colloidal membrane can be associated with other problems like immunodeficiency, hearing defects, heart problems, or it can be non-syndromic. Non-syndrome is divided into autosomal dominant, autosomal recessive, and X-linked recessive. Autosomal dominant and X-linked are relatively more common. With the clinical presentation of colloidal membrane at birth, it is difficult to predict the long-term diagnosis or long-term prognosis. This is a classification of ichthyosis congenita, where it is divided into non-syndromic ichthyosis and syndromic ichthyosis. Non-syndromic are autosomal dominant, autosomal recessive, and X-linked. Syndromic are associated with other conditions like keratitis, deafness, heart diseases, lipid storage diseases, immunodeficiency, etc. Metabolic disorders like Gaucher's disease can also present as ichthyosis or biotinidase deficiency. Other diseases are congenital hypothyroidism, Down syndrome can also present with colloidal membrane, which is very mild and encountered in a postnatal ward. So, in a relatively severe colloidal membrane, the clinical management in the neonatal period is very important because when compared to neonatal, infantile, toddler, or in the childhood period, the maximum mortality for colloidal baby lies in the neonatal period, with some case series presenting a survival of up to 55% in a severe colloidal membrane. So the important consideration in a neonatal management are fluid, electrolyte, and nutrition consideration. Like they have increased risk of transepidermal water loss, dehydration, nutrient loss, electrolyte loss, and they should be ideally be nursed in a incubator with humidification, emollient application, etc. The one part is like fluid, electrolyte, and nutrient loss. The other part is infection control. So, infection control, sepsis and pneumonia is very important. Because of this tight colloidal membrane that is compressing the extremities, the babies can have ischemia, lactic acidosis, metabolic acidosis because of decreased perfusion of the extremities. This is in the neonatal period. As the baby grows, bathing practices is more important. Exfoliation to promote scale removal, moisturizes, health monitoring, because the baby will have long-term retinoid intake, health monitoring, vitamin D levels are all important. And genetic diagnosis for perinatal counseling, preconceptional counseling is more important. So one type of colloidal membrane we'll be discussing ichthyosis congenita. This can be, as discussed previously, it can be syndromic, non-syndromic. So syndromic associated with other systemic manifestation, and non-syndromic can have different patterns of inheritance. They can present differently phenotypically and have different prognosis. So, skin biopsy can aid in the diagnosis, but this skin biopsy should be done after the membrane has shed and new membrane has formed. Examination of the hair shaft can also point towards diagnosis, but currently, because of widespread availability and ease of doing, exome sequencing is more preferred. Treatment is like monitoring of temperature, fluid, electrolyte, and nutrient intake, sepsis prevention, bathing practices that usually should be advised are like having uh, salt water bathing, like adding baking soda to the bathing water. It removes the scales. It will aid in scale removal. And dilute bleach bath, adding bleach powder to the bathing, it decreases the staphylococcus aureus colonization. And dilute vinegar, acetic acid or vinegar soaps will decrease the gram-negative bacteria and fungal infections. And scale removal should be advised. Moisturizer should be applied every 6 to 8 hourly. And retinoids, either topical or systemic, is the basis of management of ichthyosis congenita. So this is one of our baby who presented with thick colloidal membrane at birth. This baby had a eclabium and ectropion also. And baby had a constricted eye development and ear development. So baby had a microtia and also had nanophthalmus, which is a type of microtia, microophthalmia. And baby had features of ischemia like lactic acidosis, metabolic acidosis, and decreased perfusion to the extremities. Her baby also had meconium aspiration syndrome, developed one episode of sepsis, and was finally discharged after 28 days. Epidermolysis bullosa. It is an inherited mechanobullous disorders with skin fragility and tendency to develop vesicles and trauma at the site of trivial trauma. Genetic mutation can result in reduced or absent level of adhesion proteins in the basement membrane. Here the epidermis separates from the dermis with very less friction and force. There are 4 different types of epidermolysis bullosa, where I am not going in detail. This is the part of basement membrane. It typically has 2 parts, which is lamina lucida and lamina densa between the epidermis and dermis. Based on the level of lesion, it can be epidermolysis bullosa simplex, junctional epidermolysis bullosa, or dystrophy epidermolysis bullosa. Kindler syndrome, there is blistering at multiple depths within the skin. So it is more than just a skin disorder. They can have gastrointestinal, genitourinary, and ocular involvement. And nail changes are also common. These babies can have increased risk of sepsis, mainly with Staphylococcus aureus and Pseudomonas aeruginosa. Diagnosis is mostly clinical only, or skin biopsy with electron microscopy is the gold standard. Currently, exome sequencing is more preferred. Treatment is avoidance of hot microenvironment like incubator or radiant warmer. Baby should be nursed in a cool environment with AC. Air conditioning, minimizing new lesion and promotion of wound healing is more important. In case of widespread involvement, correction of fluid, electrolyte, and nutrient imbalances, prevention of sepsis is more important. So this is one of our babies who presented with aplasia cutis to present with at birth. But on careful observation, we can see that this aplasia cutis is distributed in a glove and stocking pattern. And this baby also had Nikolsky sign positive, that is like skin peeling with just a minimal trauma. And this baby also had gastrointestinal involvement in the form of duodenal atresia, requiring nutritional management. TPN at birth. Coming to the next condition, aplasia cutis, it is a congenital skin defect. It can be focal, just like some few millimeter in distribution, or it can be extensive. And it can be just absence of epidermis or dermis, or occasionally the subcutaneous tissue involving right up to bones also. 70 to 90% the lesions are localized on the scalp. Solitary lesions are more common than multiple lesion. The most commonly used classification is Frieden's classification, where it is divided into 9 groups. So group 1 is more commonly encountered like scalp aplasia cutis without other anomalies. Just you have a small patch of aplasia cutis in the scalp. There will not be any underlying bone malformation, limb abnormalities or underlying disorder. Nothing will be there. And group 1 is a more common. Group 2 is scalp aplasia cutis associated with limb abnormalities like Adam-Oliver syndrome. It is also known as Adam-Oliver syndrome. Group 3 is associated with epidermal or organoid nevi. Group 4 is this everyone would have seen. Meningomyelocele, gastroschisis or amphalocele, we have seen that there is no skin overlying. But that is also known, that is called as group 4 aplasia cutis. This group 5 aplasia cutis is associated with the fetus papyraceous in a twin gestation or in a placental infarct. In group 6, the aplasia cutis is associated with epidermolysis bullosa as in our previous case. Group 7 is localized to extremities without blistering. Group 8 is caused due to specific teratogen, and Group 9 is due to associated syndromes of malformation. Scalp ACC has complications of bleeding, thrombosis, ulceration, secondary infection, and it can also cause hydrocephalus. Scalp lesions warranting further evaluation or if the size is more than 4 centimeter or if there is presence of hair collar or tufting in the periphery of aplasia cutis, neurological deficits or hemorrhagic lesion, they will need more evaluation in the form of neuroimaging to rule out intracranial malformation. Diagnosis is mostly clinical with or without a histopathological examination. Usually, even in the case of extensive aplasia cutis, just conservative management is more appropriate, and currently the treatment of choice is conservative management only. Mortality in the case of extensive scalp lesion or systemic lesions is around 20%. So this is one of our case who was admitted with this aplasia cutis. We can see that in a same baby at the same day of examination, there is active aplasia cutis in certain region, and there is healed aplasia cutis in the peripheral region. In the back, it is almost healed, and in the front, we can see that it is typically distributed in a H-type pattern. This is aplasia cutis congenita type 5 that was associated with placental infarct. Next, coming to neonatal biotinase deficiency. It can be due to multiple carboxylase deficiency, holocarboxylase synthase defect, or biotinase deficiency. Holocarboxylase synthase deficiency, it manifests in the neonatal period, and biotinase deficiency, it causes infantile biotin deficiency after 3 months of life. Biotin acts as a coenzyme for 4 carboxylase, mostly the fatty acid synthesis defect, gluconeogenesis, and amino acid catabolism. Clinical feature, they present with a bilateral, symmetrical, well-demarcated periorificial in intratriginous dermatitis, alopecia, or it can present with colloidal membrane or ichthyosis. So in any baby with ichthyosis and colloidal membrane, if the baby is having severe metabolic acidosis and organic aciduria, then neonatal biotin deficiency has to be considered. They will also have neurological manifestation like seizures, lethargy, projectile vomiting, abnormal muscle tone, athetosis, and altered sensorium. Diagnosis is usually by urine GCMS, enzyme assays, and exome sequencing. And treatment is lifelong high-dose biotin supplementation. So, neonatal skin emergencies. Dermatological emergency, they will need early diagnosis, hospitalization, careful monitoring, and multidisciplinary intensive care to minimize associated morbidity and mortality. It is more common in neonatal dermatosis, especially epidermolysis bullosa, colloidal membrane, and harlequin ichthyosis, and staphylococcal scalded skin syndrome. The two main groups presenting as neonatal dermatological emergencies are genodermatosis and infections. In children, atopic and seborrheic dermatitis present as erythroderma, and in children, infections and cutaneous drug reactions should also be considered. So, if we see the mortality rate in a case series of neonatal dermatological emergencies, it is relatively high for infections like necrotizing fasciitis, varicella infection, herpes simplex infection, purpura fulminans, scleroderma neonatorum. It is almost reaching 100%. However, for ichthyosis congenita, neonatal erythroderma, it is relatively rare. I mean, less. The classification are primary dermatological emergencies and dermatosis associated with medical or surgical emergencies. Associated with medical or surgical emergencies are purpura fulminans, Kawasaki disease, and scleroderma neonatorum. Primary dermatological emergencies can be neonatal erythroderma. So, when we are seeing the morphological diagnosis, we have to see whether the baby is having papillosquamous disorder or vesiculobullous disorder, or baby is having erythroderma. Uh, like papillosquamous disorder can be due to psoriasis, pityriasis, rubra pilaris, and these Omenn syndrome, graft versus host disease skin can also present as papillosquamous disorders. Like Langhans cells, LCH, diaper dermatitis, it all present as papillosquamous disorders and erythroderma. Infections, bacterial infections, viral and fungal, we have discussed earlier. In vesiculobullous disorder, where there will be predominant of vesicles, bulla, erosions, and ulcer, the important diagnosis epidermolysis bullosa. This is DDs for vesicles. So neonatal erythema, baby will be red and scaly baby. If you recall, we could have seen the same picture for congenital HSV infection, congenital fungal, congenital cutaneous candidiasis, they are almost similar. In staphylococcal scalded skin syndrome, they are almost similar. So the syndromic diagnosis will be neonatal erythroderma, where the involvement of skin will be more than 90%. Irrespective of the underlying etiology, it is a rare and life-threatening condition. The hospital-based incidents are 0.11%. The most common two groups are infections and genodermatosis. The two core principle of managing a neonatal erythroderma baby is management of temperature, electrolyte, fluid, and nutrition balance. The other is infection prevention. So they can have increased transepidermal water loss. They can present with hypernatremic dehydration. Actually, they can have hyperthermia, hypothermia. They can have hypernatremia, hyponatremia. They can have dehydration or fluid overload because of hypo or hyperhidrosis. So this supportive management and prevention of infection is very important. So this is the clinical and lab monitoring. Clinical monitoring is serial measurement of body weight, monitoring of signs of dehydration, serum sodium, urine output, urine specific gravity, osmolality, blood gas, and monitoring for renal function all will be required. This is the principle of nutrition management. Coming to purpura fulminans, it is a severe. We can see that here the involvement is more in the lower limbs and in the gluteal region. Here the gluteal region, and the lesions can be of varying age. Some lesions are new, some lesions are old. These are purpura fulminans. So it is acute syndrome. It can be due to inherited protein C deficiency, or it can be due to infections. It is a rapidly progressive skin. It is due to rapidly progressive skin necrosis and disseminated intravascular coagulation. It can be hereditary, caused by congenital protein C deficiency, or due to infections like group B streptococcus, gram-negative bacilli like E. coli, enterobacter, and staphylococcus. In case of congenital protein C deficiency, they present as a DIC-like picture. Increased D-dimer, low fibrinogen, increased fibrin degradation products, low platelet, increased PTINR. For proving protein C deficiency, protein C activity can be done or exome sequencing can be done. For proving infection, blood culture should be taken. Treatment irrespective of the underlying condition, heparinization, transfusion of FFP and prostacyclin can be used. Mortality is almost 50 to 100%. This was one of our cases with congenital protein C deficiency that presented with purpura fulminans at around 2 weeks of age. This is the gluteal region that is almost healed with necrotic elements. This was one of the old back lesion. So treatment is since we don't have plasma derived protein C concentrate, we usually transfuse fresh frozen plasma 20 to 30 ml per kg every 6 hourly. So long line should be inserted, and monitoring for features of fluid overload is very essential. Activated human protein C and warfarin can be given in case of protein C deficiency. Scleroderma neonatorum, I don't have any picture, but every one of you would have been encountered Scleroderma neonatorum. It is basically a form of severe panniculitis, inflammation of the subcutaneous fat. It involves sudden onset of diffuse hardening of the skin, initially involving the lower legs, spreading to thigh, buttocks, trunks, and cheek. Palms and soles are usually spared. It can not only occur in sepsis, it can also occur in dehydration, intracranial hemorrhage, congenital malformations, respiratory and GI diseases. Pathogenesis is unknown, but it can be due to abnormal fat metabolism or fat hardening and low body temperatures. Histopathological examination will just involve inflammation, reveal inflammation of the adipose tissue. Lab abnormalities can be electrolyte disturbances, hypoglycemia, azotemia. Supportive treatment is more important, but in spite of this, the case fatality rate is almost 50 to 100%. I am skipping neonatal Kawasaki disease. I am skipping normal skin findings. So conclusion, the neonatal skin is a very complex organism with a range of clinical presentation which can range from benign to serious. Newborns usually present with benign transient skin findings which only needs reassurance and conservative management. Any affection of the skin, additional inspection of the hair, nails, mucous membrane and CNS is needed because they all have a same developmental origin ectoderm. Accurate primary morphological diagnosis and spatial diagnosis, like whether it is a macule, patch, papule, nodule, or a tumor. Morphological diagnosis is important and spatial diagnosis is important, and it is the initial step in etiological diagnosis. The secondary findings like ulcers, erosion, superadded infection should not be confused. Knowledge of clinical presentation, rapid diagnostic methods, emergency and intensive care, and monitoring of the progress can help in comprehensive care of neonates and decrease the mortality. Thank you.
Thank you, Dr. Aruna, for such a extensive presentation. And knowingly, we have not covered the vascular malformations as it will be beyond the scope of today's discussion. Without wasting much time, I would like to open the discussion part. Now, all others' comments are invited. Let us see chat box. Any comments are there? Questions? Okay, so one question was there. I had seen. So somebody has asked whether to isolate the baby if mother has scabies. Dr. Aruna, you like to answer?
Ma'am, in any infections, we don't isolate the baby and mother. So if the mother has scabies also, we usually advise treatment for all the family members rather than isolating the baby and mother.
Correct. Scabies is a contagious disease, so all family members has to be treated. It is vice versa. If baby has scabies, mother doesn't have also, we have to treat mother, father, both. And simultaneously, we have to tell the parents to heat treat all the clothes and sun dry it as early as possible. Any other questions? Are you able to see any other questions, Aruna?
Just one question only.
Okay. Okay, if there are none, then we can close the discussion.
Yes,
Good night, all.
Thank you, ma'am. Thank you. Thank you, everyone.
Good night.